ACL deficiency. ACL length is 3 cm. Diameter is 1 cm. Two bundles, anteromedial and posterolateral bundle. Anteromedial tight in flexion and more isometric. Gives anteroposterior stability. Lachman test to be done to test it. Posterolateral structure tight in extension. More horizontal rotational stability. Damage responsible for pivot shift phenomena. Plus anterolateral ligament. Anterolateral ligament is bearing load in setting of ACL tear. Regarding ACL, 90% is type 1 collagen. Origin from lateral femoral condyle, insert anteriorly and between intercondylar eminence. Strength is 2200 newtons. Innervated by middle geniculate artery. Nerve supply, tibial nerve and mechanoreceptors. In ACL injury is more common in females than males, 4:1. Study done by Sutton et al. 2013. Number 1, there is neuromuscular imbalance is the most important significant factor. Number 2, quadricep dominant. Number 3, lands in more extension with high valgus moment arm. Number 4, small notch and ligaments in females. X-ray, Paul Segon fracture, cortical avulsion of lateral capsule of the tibia at the tibial insertion, or anterolateral ligament from lateral femoral condyle to lateral tibial plateau between Gerdy's tubercle and LCL, structure within the capsule. Segon fracture, when it happens, it is one of the ACL injury. It's pathognomic for ACL injury. For MRI, in sagittal view, there will be ACL fiber discontinuity, bone bruises, middle of the lateral femoral condyle and posterior 1/3 of lateral tibial plateau. On coronal view, empty notch sign, fluid against the lateral wall. Management, McDaniel's rule of 1/3. 1/3 would compensate, 1/3 would avoid, compensate well with conservative management, 1/3 would avoid symptoms and modify activities, 1/3 do poorly and required surgery. Initial management, bracing and physio, close chain exercises, foot on the ground. Frobel et al. Showed that no difference in outcome with surgery, early surgery, or non-operative rehab, but there is increased risk of medial meniscal injury and chondral damage with non-operative management. Associated injuries, MCL injury. If there is MCL injury, allow MCL injury to heal and then perform ACL reconstruction. Valgus varus instability will jeopardize the graft. Meniscal tear, delay repair of lock knee due to coexisting bucket handle tear would lead to fixed flexion deformity. So repair acutely. Avoid ACL reconstruction in knee with loss of knee extension because they don't regain full extension. Posterolateral collar injury, repair as same as ACL or as a first stage of two-stage reconstruction. Complications, cyclop lesion, fibroproliferative tissue developed which blocks extension, kneeling difficulty, ongoing instability can be due to improper femoral tunnel, graft failure is common usually in 2 years due to impingement of or enlargement of the tunnel, adverse soft tissue reaction synovitis appears late 5 years, arthrofibrosis, osteoarthritis. In ACL, if ACL is deficient, there is posteromedial osteoarthritis. In osteoarthritis with ACL intact, there is anteromedial osteoarthritis. Regarding the graft, PTB has 2600 Newton strength. Bone to bone healing in 6 weeks. can lead to pain while kneeling, increased chance of patellar fracture, patellar tendon rupture, and patella baja, hamstring 4 strands. Similar functional outcome to BTB, less bone donor site for morbidity. Slow healing takes 8 to 12 weeks. Risk of saphenous nerve injury. Load to failure 4000 newtons. Quadricep used for revision, high thick but short tendon. Allograft should be non-irradiated Achilles or tibialis anterior tendon. The benefits are lack of donor side morbidity, high re-rupture due to sterilization process, gamma radiation, inflammation, synovitis, osteolysis. Better results with Luke and LAR ligament, but no long-term results. LARS is ligament augmentation and reconstruction system. Another possibility is Gore-Tex. Gore-Tex is PTFE, or called expandable polytetrafluoroethylene. LARS is terephthalic polyethylene polyester fibers. A Cochrane study showed insufficient evidence to determine relative effectiveness of double bundle ACL and single bundle reconstruction. Limited evidence about double bundle reconstruction has superior result in objective measurement of knee instability and protect against re-rupture or new meniscal injury.